Hi, this talk is the third and last talk about EEG electrodes. It deals mainly with surface EEG electrodes and, to a lesser extent, with other types of electrodes used in neurophysiology. The objectives of this talk are to explain surface EEG electrode placement, to correlate placement with anatomy, and to briefly mention a few facts about non-surface EEG electrodes. I will conduct this talk in a question and answer style. As I have done in the past, I recommend you to pause this flick on each question, read it, answer it, and only after you have done so to continue rolling. Here goes the first question. Which of the following structures is not a bony landmark used for EEG surface electrode placement? A. Nasion, B. Inion, C. Preauricular point, D. Vertex. The placement of surface EEG electrodes starts by determining bony landmarks. The only instruments needed for proper surface EEG placement are a measuring tape and a non-toxic skin marking pencil. The process starts by finding three bony landmarks. These landmarks are the nasion. The nasion is the indentation between the forehead and the nose. The preauricular point. The preauricular point is the indentation just above the tragus. And the inion. The inion is the ridge of the knob that you feel as you move your finger up through the midline region of the back of the neck. This ridge is at times difficult to find. If, despite asking the patient to move the neck back and forth, you still have difficulty finding it, mark the inion at the level of the preauricular point as it is shown in this figure. So the answer to this question is D. The next question is, which of the following electrodes should be assigned first during surface EEG electrode placement? A. A1, B, ZZ, C, T7, D, T8. This question is just an excuse to tell you how I was taught to place surface EEG electrodes. The best way to think about surface EEG electrode placement is to consider the head as a double circle, divided in quadrants with the nose and the ears added to the other circle. The gray lines within the circle represent the temporal lobes and the central sulci. I will use this figure multiple times during this talk. Now I will start telling you about the mechanics of electrode placement. Electrode placement is done following the modified 10-20 system guidelines. I was taught to do it in 10 steps. The first step consists of placing the midline electrodes. I have in this frame colored the midline line in green, added blue circles to indicate electrodes, and introduced letters as labels. I added the blue circle to give you an idea of how the head would look after the placement of midline electrodes. As we just mentioned, the midline electrodes are placed first. The first letter of each designation stands for the cerebral lobe the electrode is at, except for the letter C that stands for the central region. The last component of the designation is usually a number, except for those electrodes in the midline region, as we can see in this frame. In the midline electrodes, the letter C is used. The letter C stands for 0. FP stands for frontal polar. I have introduced this figure to you before when talking about landmarks, and here I will use it to describe EEG electrode placement in the midline region. The first measurement we take is between the nasion and the inion along the midline. We place the first electrode 10% of the total distance from the nasion to the inion. This location is considered the FPC site. The next placement is 20% above the FPC site, and this is the location for FC electrode. 20% above that is CC, 20% above that is PC, 20% above that is OC, and from OC to the inion there should be the same distance as from FPZ to the nasion. That is 10% of the total distance. So look from above, the head should look as in this picture. And in the imaginary diagram of the head we made initially, it would look as it does in this frame, with 5 potential sites for electrodes. I say potential because most EEG technicians prefer to mark the whole head and then place the electrodes, and because not all the marked sites are used for electrode placement in every patient. The second step I was taught to do is the placement of tentative T7 and T8. Last time, in the last frame, we ended up with a figure just like this one, which I will introduce again here. Now we go to the preauricular point and measure from the left preauricular point to the right preauricular point going through CC. Then we go to the left side. Following the line we just made, we mark 10% up from the left preauricular point. This is the location for tentative T7. We do the same for T8. Looking from above, this is how the head would look once both sides are done. Note that the odd number is to the left and the even number is to the right. The third step is to determine the sites for FP1 and 2, F7 and 8, the final sites for T7 and T8, the sites for P7 and 8, and for O1 and O2. This is how the imaginary diagram of the head would look once this bunch of electrodes are in place. As you can see, I have colored the inner circle in green and added 10 new electrodes. I will use the left side for demonstration. The distance from FPC to OC is measured going through tentative T7. The same is done on the opposite side. So now, view from above, the head will look as you see in this frame. The sagittal line has been crossed by the circular line. In the front, indicated here by the formation of a cross, we mark the site for FPC. and in the back we label the OC site also by the formation of a cross. From this point on, when we talk about the circumference of the head, we refer to the measurement going through FPC, tentative T7, OC, and tentative T8. I will convey this situation by extending a line from FPC and also from OC. Then we take the distance from FPC and OZ on one side and use this value as 100% for future calculations. Then we mark 10% of this distance going from FPZ to OC. Then we mark 20 more, then 20 more, then 20 more, and again 20 more, and we are left with 10%. I like to emphasize that the percentage here given correspond to half the head circumference, but if instead we consider the full head circumference, then the percentage would have to be half. But for the moment, it is fine to keep it as we have done from the beginning. So at this junction, we draw a line at the 50% mark between FPC and OC. This line goes from one side of the head to the other. So it is where this horizontal line crosses the circular line on the left side that we place the definite T7. From this side going forward, we measure 20% and mark the site for F7, 20% more to place FP1, and make certain we are left with 10% of the distance of half the head circumference between the site of FP1 and FPC. Then we follow the same exercise towards OZ. 20% from T7 we place P7, 20% from P7 we place O1, and make sure that 10% is left between the places for O1 and OZ. The fourth step we take in the process of placing surface EEG electrodes is to determine C3 and C4. I have represented in this diagram the intended location. We do the left side first. We measure the distance between ZC and T7 and half it. So we determine the site for C3 and do the same for C4 on the other side. The next step is to determine the site for F3 and F4. Pointed by the green arrows at their intended location in this diagram. We do this on the left side first by drawing a line between F7 and FC and halving it. It is at this site that we place the electrode for F3. Then we do the same on the right side. The sixth step is to determine P3 and P4. This diagram shows the intended sites. Again, we start on the left side of the head and just mirror the steps on the right. First, we draw a line between P7 and PZ, then halved it, and that is the site for P3. And then we do the same thing on the right. So at this point, the left side of the head looks like it does in this frame. Recapping what we have done so far, we start with 5 potential sites, then 15 potential sites, then 17 potential sites, then 19 potential sites, and then 21 potential sites. But it is not over yet. Next, we place A1 and A2. We again go to the left side and place A1 at the earlobe. It can also be placed on the mastoid. We do the same thing on the right. Once these ear electrodes are placed, the diagram would look as you see in this frame. The 8th step is a strange one. It is the removal of FPC and OC, since they are usually not used in regular recordings. So if we are looking at the skull from the left, I first remove FPC, then I remove OC, as I have done in these frames. So the diagram will look as you see it in this frame. Then I take the 9th step. The 9th step is placing the ground. The ground can be placed at different sites, but within the head. Usually it is placed in the midline of the head or over one of the mastoids. In this frame I have placed it in the frontal region, as you can see. The final step is placing an additional electrode that is called the reference. This electrode was added when digital filtering was implemented. Most neurophysiologists like to place this reference somewhere in the midline of the head. A common location for putting this reference is where it is indicated here by the yellow circle. This frame shows the input box of the equipment currently used at Nicklaus Children's Hospital, formerly Miami Children's Hospital. It has 22 channels for electrodes within the figure representing the head and ears, 1 channel for the ground, and 1 channel for reference. So, since I asked the question a while back, I will repeat it here. The first electrode location to be assigned is A1, B, CC, C, T7, T, T8. The answer to this question is B. Next question. The reference electrode in a digital EEG machine is connected to the ground to make the ground more stable. A true, B false. I am going to spend probably more time than I should during this talk on this question. I will do this because most books do not mention this electrode. The reality is that in a purely analog equipment, the differential amplifier compares the charges, here represented as blue for positive charges, entering through G1 to the charges entering the amplifier through the ground. In this figure, this operation is resulted as 5 positive charges because the ground in this example is neutral. The same occurs when the charges entering G2, here depicted as red circles, representing negative charges. The result of this operation is 4 negative charges. Next, the differential amplifier subtracts the number obtained by these operations and produces a result that is translated into vertical displacement of the signal over time. I will, in the following frames, label each electrode using the conventional EEG nomenclature. So we are going to make the one on top FP1 and the lower one F7. This new diagram is nothing more than the diagram I have just presented but made smaller. In this frame I am introducing the derivation they constitute. I have done this to give me room in the following frames to introduce an array of electrodes, as I have just done representing a bipolar montage, using the non-modified 10-20 system guidelines, and on the other side of the frame a common referential montage using similar electrodes. I will first explain the figure on your left. As I just mentioned, the figure on your left is a diagram of a so-called bipolar montage, going from FP1 to O1. As you can see, indicated by the brackets, the same electrode used in G2 of the upper amplifier is used as G1 in the lower amplifier. As we previously mentioned, the voltage entering through G1, as an example in this frame through FP1, in the first amplifier will be subtracted from the voltage entering through the ground to the amplifier. The voltage from F7 entering through G2 of the same amplifier will also be subtracted from the voltage coming to the amplifier through the ground. Then the result of these two subtractions will be subtracted from each other. Each of these subtractions has a different purpose. The first subtraction removes the influence of the ground from both, for example, remove 60 Hz artifact. The second subtraction enhances what is different between G1 and G2. I will talk more about this in the future when we talk about amplifiers, but for now I think this explanation will suffice to understand the reason for using a reference electrode during digital recording. I'd like for you, before starting to talk about digital EEG, to take a moment to look at the figure on the right. The only difference between the figure on the left and on the right is that the figure on the left shares electrodes between amplifiers, and the figure on the right has a common electrode entering through the G2 of each amplifier. The reference, that is the electron entering through G2, in this case is selected by the technician. In the next frame I am going to take you to a different world. That is the world of digital EEG. For the explanation of digital equipment, I will use the modified 10-20 system guidelines. Take a moment to look at this figure. In the digital world, this diagram is used in all instances to reconstruct bipolar montage, common referential montage, or any other montage. And this is all achieved by the introduction of a common reference to all differential amplifiers entering through G2. By this approach, a single value is given to each amplifier and thus to each electrode entering through G1. The arrow in this case indicates the value of FP1, the value of F7, the value of T7, the value of P7, and the value of O1. Notice that all are in quotation marks. I have done this to indicate that they cannot be used without further processing. The processing will start by giving it a value using the binary numerical system. That binary numerical system is later manipulated and ultimately displayed, in this case as a bipolar recording, or as a referential montage using whatever reference is desired by the reader. Sorry I have taken so long discussing this question, but I think most books on the subject do not cover it, and I wanted you to have an operational understanding of the subject. So the answer is B. The reference electrode of the digital EEG machine is used to have a single common currency value that allows comparison between the different electrodes. The next question is, the minimum number of scalp electrodes for EEG recording in an adult should be A10, B19, C21, D25. This frame presents a diagram of the 10-20 electrode placement. The number of electrodes usually considered the minimum to record a regular adult EEG in the United States is 21 electrodes plus a ground. So the answer to this question is C. Nevertheless, in Canada, going by the 2002 recommendation, the number of electrodes, the least number of electrodes that should be used, is said to be 16. Next question. In the modified 10-20 system, T3 becomes T7, A true, B false. In the initial 10-20 system, electrodes were labeled T3, T4, T5, and T6. These electrodes have been changed in the modified 10-20 system currently in use. So T3 has become T7, T4 has become T8, T5 has become P7, and T6 has become P8. So the answer to this question is A. The localization error of a dipole source using 21 electrodes is in the order of dash millimeters. A 20 to 30, B 4 to 10, C 2 to 5, D 40 to 50. Pause the flick for a few minutes and read this abstract. It is interesting that in the experimental model created by Evert et al., when increasing the number of electrodes from 19 to 32, localization improves by 2.7 millimeters. And when going from 32 electrodes to 63 electrodes, localization improves by less than 1 millimeter. In the same paper, Evert et al. Quoted a paper by Mosher. I have enlarged the conclusions arrived by Evert about the paper written by Mosher looking at error in the vicinity of the electrode array. As you can see by reading the enlarged paragraph below, the conclusion is much different. I will summarize it in the following frames. The first column in this frame indicates the number of electrodes being used. The number in the yellow bar indicates the distance in millimeters between the real source and the perceived source. When using 21 electrodes, the distance between the real source indicated by the arrow and the perceived source could be as little as 20 millimeters to as much as 30 millimeters. When using 37 electrodes, the distance between the real source and the perceived source could be as little as 4 millimeters to as much as 10 millimeters. On the other hand, if 127 electrodes are used, the distance between the real source and the perceived source could be as little as 2 millimeters or as much as 5 millimeters. So as you can see, there is conflicting data regarding the benefit of closely placed electrodes. But despite the conflicting information, that reveals that on one hand, increasing the number of electrodes improve localization by a matter of a few millimeters, but on the other hand, that the more electrodes, the smaller the difference between the real and the perceived source. The most widely accepted conclusion is that for precise localization, more electrodes are better than fewer electrodes, and that 21 scalp electrodes allows localization within about 2 to 3 centimeters of the real source. So the answer is A. I quoted Ebert on the article by Moshe because I tried reading the article from Moshe by myself and I was unable to read it because of its high complexity or my narrow understanding of math that went into their calculations. The next question is increasing the numerical value as electrodes distance themselves from midline is an innovation for the first time introduced in the modified 1010 system. A true, B false. This, as you know, is a diagram of the 1010 system. As you can see, the further an electrode is from the midline, the larger the number becomes. This is a drawing from 1949, and as you can see, increasing the numerical value the further an electrode is from the midline is not a new idea. So the answer to this question is B, false. PG stands for A, nasopharyngeal electrode, B, inion electrode, C, pharyngeal ground electrode, D, oropharyngeal electrode. PG stands for nasopharyngeal electrode. The nasopharyngeal electrode is introduced through the nose and advanced to the pharyngeal region. This electrode is no longer in use. So the answer to this question is A. The next question is M stands for A, mastoid electrode, B, mandibular electrode, C, pharyngeal electrode, D, oropharyngeal electrode. This is a drawing of the skull, and as you can see, the arrow points to the mandibular region. M often is used to indicate mandibular, but at times it's also used to indicate mastoid. So the answer to this question is B, but not all agree. Some use the M for mastoid instead of for mandibular. Next question. If the head circumference is 50 centimeters, what is the distance between FP1 and FP2? A, 10 centimeters, B 5 centimeters, C 20 centimeters, D 12 centimeters. The arrow in this frame points to FP1, in this frame to FP2. As you can see, they are quite close to each other. The distance between these two electrodes can easily be calculated by going back to one of our initial figures. When considering half of the head circumference for calculation, the distance between FPC and FP1 is 10%. But if we consider the full head, the distance between FPC and FP1 is 5%. So the distance between FP1 and FP2 is 10% of the full head circumference. So 10% of 50 centimeters is 5 centimeters. So the answer to this question is B, 5 centimeters. Using the 10-20 electrode system, if the distance between the nasion and the anion is 40 centimeters, what would the distance from FC to PC be? A, 16 centimeters, B, 24 centimeters, C, 5 centimeters, D, 10 centimeters. By looking at this figure, we can see that the distance between FC and PC is 40% of the total sagittal distance. So 40% of 40 is 16. So the answer to this question is A. The next question is, which of the following is true regarding the Silverman's electrode? A, often referred to as electrodes T1 and T2. B, location 1 centimeter above, where the anterior 1/3 and posterior 2/3 of a line connecting the outer canthus of the eye and the tragus meet. C, records from the anterior basal area of the temporal lobes. D, all of the above. In the next frames, I will illustrate the position of the Silverman's electrode. You draw a line connecting the outer canthus of the eye and the tragus. You divide it in thirds. You go where the anterior 1/3 and posterior 2/3 of the line meet, and you put the electrode 1 centimeter above. On the left side, the Silverman's electrode is often labeled T1 or left true anterior temporal electrode. The Silverman's electrode surveys the anterior basal area of the temporal lobe. In the 10-10 system, the closest electrode to the Silverman's electrode is labeled as F9. So the answer to this question is D, all of the above. Next question, amplitude increases with inter-electrode distance up to A, 10 centimeters, B, 20 centimeters, C, 30 centimeters, D, 40 centimeters. The answer to this question is 10 centimeters. So the answer is A. The next question is, if C4 electrode is relocated 2 centimeters further from T4 and nearer to CC than its normal position, the homologous C3 electrode site should remain in its regular position. A note to this effect should be written in the report. A, true, B, false. In this frame, a lesion at the site of C4 is represented by a red blob. The presence of such a lesion forces us to move C4 to the side. The correct approach is to move C3 to the homologous position on the other side, as you see depicted in this frame. So the answer to this question is B, false. If a midline electrode needs to be relocated, just move it to the side and align all other midline electrodes with a newly relocated electrode. A, true. B, false. If a small lesion prevents CC placement at the regular site, it is incorrect to move CC and the rest of the midline electrodes to the side as it is shown in this frame. The correct approach is to move CC backwards or forward, but keeping it in the midline. So the answer to this question is B. Next question. If CC electrode cannot be relocated to the midline because of a long midline lesion, just move it to the side. A, true. B, false. It is incorrect to move CC to the side when CC cannot be moved to a more anterior or posterior midline position. The correct approach is to add C1 and C2 electrodes as shown in this frame. So the answer to this question is B. The next question is, when confronted with a raised deformed area where an electrode should be located, the correct action is to place the given electrode halfway between its adjacent electrodes in the anterior-posterior line, but to keep the regular distance in the transverse line. A, true. B, false. When confronted with a patient that has a swelling in the scalp area as depicted in this frame, a decision must be made as to where to place P3. In this event, the best result is obtained by locating the two closest not involved electrodes in the transverse or coronal line. In this case, they are P7 and PC. Measure the distance between them, which in this case, let's say it is 16 centimeters, and divide this distance in half. Then placing tentative P3 site at this location. So the distance between tentative P3 and P7 is 8 centimeters, and between tentative P3 and PC is also 8 centimeters. The homologous electrode, that is P4, is placed following the usual rules for electrode placement, that is 1/2 the distance between P8 and PC. The same exercise should be done in the anterior to posterior line. In this case, the P3 location should be half the distance between O1 and C3 at the level previously selected. So, if the distance between C3 and O1 is 10 centimeters, P3 should be placed 5 centimeters from each of them. On the normal side, P4 should be placed in its regular position. So the answer is B. I included here a segment from an old manual from the Grass Company. If you get a hold of it, read it. The next question is, F4 is closer to the coronal suture than C4. A, true. B, false. By now, I think that you have a good mental picture of this figure. It depicts the placement of surface EEG electrodes using the 10-20 system. I placed this new figure in this frame because it gives you a good perspective of the cerebral structures in relation to the sutures. The arrow points to the coronal suture, here to the escamosal suture, here to the spheno-escamosal suture, here to the occipital mastoidal suture, here to the lamboidal suture. And what impressed me the most is how far the frontal lobe extends beyond the frontal suture, as you can see pointed by the arrow. Here the arrow is pointing to the supramarginal gyrus, and here to the angular gyrus. In this frame I have added the common locations of the most frequently used electrodes. I have in this frame labeled C4 and F4 electrodes. It does not take long looking at this figure to answer the question. The answer is A. Next question. Which electrode best records activity from the left anterior temporal region? A. T5, B. T4, C. F7, D. T7. This frame includes a figure of a child's head. The F7 electrode most accurately views the tip of the temporal lobe than any other when using the regular 10-20 system. This is a view of the head from above. The most common used electrode sites are indicated. The line just added represents the central, and the semi-elliptical structure represents the contour of the left temporal lobe and the right temporal lobe. So the answer to this question is C. Next question. Using the 10-20 electrode system, how can you tell if an activity maximal at F7 arises from the anterior temporal region? A. T7 is also involved. B. T8 is also involved. C. F3 is also involved. D. F4 is also involved. Here we have represented the child's brain. In red, I have superimposed the location of a lesion. That is, the lesion is over the anterior temporal region. As we have mentioned, such a lesion usually produces maximal involvement of the F7 electrode, but often the field expands to T7. I have added the diagram of the EEG placement that I have shown you so many times just for clarity. So the answer is B. Next question. Using the 10-20 electrode system, how can you tell if an activity maximal at F7 arises from the inferior frontal lobe? A. T7 is also involved. B. T8 is also involved. C. F3 is also involved. D. F4 is also involved. The lesion represented in red is located at the inferior frontal lobe. An abnormal activity arising from such a location has maximal EEG representation at the level of F7, but the field would extend to F3. You can see this distribution again displayed in the electrode diagram that we have used so often. So the answer to this question is C. Next question. Which electrode records from Wernicke's area in most right-handed people? A, T7, B, P7, C, P8, D, P9. The electrode that best records the posterior region of the superior temporal lobe, where the area of Wernicke is in most patients, is best captured by P7. Remember that in the pre-modified 1020 system, P7 was called T5. So the answer to this question is B, P7. Which electrode is likely to pick up activity from the right angular gyrus? A, T2, B, T5, C, T4, D, O1. The angular gyrus is posterior to the supramarginal gyrus in the parietal lobe. The electrode that best captures electrical activity from this area is P4, here represented or indicated by the arrow in the diagram. So the answer is P4. Next question. Which electrode is likely to pick up activity from the right cortical area for saccadic eye movements? A, T8, B, F4, C, T5, D, O1. The electrode best suited to capture this area is F4. You can see the location of F4 in the EEG diagram. So the answer to this question is B. Next question. In which lobe is electrode placement different in neonates than in adults during regular EEG recording? A, frontal, B, central, C, parietal, D, occipital. Concerning EEG placement in neonates, we have alternatives. I will start by showing an electrode placement diagram using the 10-10 system. I have changed the color to yellow in those electrodes I'd like to concentrate our attention. The arrow points to the left frontopolar electrode and in this case to the right frontopolar electrode. One alternative in neonates is to move those electrodes I just mentioned to the F1 electrode location and the F2 electrode location in neonates. In this frame, I have labeled the same electrodes as I labeled in the electrode placement diagram. As you can see, F1 is very close to the midline and therefore very close to F2. One good thing about placing the electrode so close to the midline is that the EKG artifact from F1 is tolerable. I will now address the second alternative. This alternative is to move FP1 and FP2 just a little backwards to the left anterior frontal electrode and the right anterior frontal electrode. Electrodes in this site are further from each other, which is desirable, but usually the left anterior frontal electrode is very vulnerable to cardiac artifact. So the answer to this question is A. The next question is, needle electrodes should be made of A, steel, B, platinum, C, A and B, D, gold and silver chloride. Needle electrodes should not be used for regular EEG in neonates. That is just my opinion. If they are to be used, they are to be made of steel or of platinum? So the answer to this question is C. Next question. Nasopharyngeal electrodes record from the basal part of the temporal lobe. A true, B false. In this frame, I have superimposed on an MRI an approximation of the nasopharyngeal electrode location. The main function of the nasopharyngeal electrode is to clarify activity noted by other electrodes. In reality, it captures too many artifacts and makes small sharp transient of sleep look big and reminiscent of epileptiform activity. The nasopharyngeal electrode records from the basal region of the temporal lobe. So the answer to this question is A. Next question. Sphenoidal electrodes' main value is to distinguish between mesial and lateral temporal lobe seizures. A true, B false. Sphenoidal electrodes' main value is to distinguish between mesial and lateral temporal lobe seizures. Hence, when seizures arise from the lateral temporal lobe, no spikes would be present in the recording, but if they are arising from the mesial temporal lobe, they will have discharges recorded. I doubt very much that you would ever use an sphenoidal EEG electrode, so I will not explain its insertion. In the past, I have placed a few of them. Overall, I think patients tolerate having the procedure done better than I tolerate doing it, but still, not much was ever gained from doing them. I include them here because I have seen a question on the board regarding sphenoidal electrodes and the foramen ovale. Yes, the tip of the sphenoidal electrode should be close to the foramen ovale. So the answer to this question is A. The next question is: synchronous cortical activation of more than 2.8 centimeters in diameter is needed to produce a scalp recorded EEG potential. A true, B false. The answer to this question was published in Epilepsy in 2005. I will walk you through the relevant parts of this article. The purpose of the study was to determine the cortical generators of scalp interictal spikes. The method can be briefly understood by looking at the next frame. The arrow points to the electrode grid used during the testing. Below are the specifications of this grid. This frame shows an image of the brain with the superimposed electrode grid in black. The important information in the result were that when the cortical area spiking was more than 10 square centimeters, scalp spikes were recorded in 90% of the cases. When the cortical area was less than 10 square centimeters, scalp spikes were recorded in 10% of the cases. When the cortical area was less than 6 square centimeters, spikes were never recorded. The conclusion of this study was that for scalp EEG spikes to be recorded, a large area of cortex must be involved. This area must be in the order of 10 to 20 square centimeters. So where do the 2.8 centimeters come from? From this book. from this paragraph and from the fact that the area of a circle with a diameter of 2.8 centimeters has an area of about 6 square centimeters. So the answer to this question is A. Which of the following is not used for sterilization of surface EEG electrode used in patients with Creutzfeldt-Jakob disease and hepatitis B virus? A. 5-sodium hypochlorite. B. 70% alcohol. C. Ultraviolet irradiation. D. Steam autoclaving. In 2016, at Nicholas Children's Hospital, we only used disposable electrodes. I think most institutions are doing the same thing. When not disposable electrodes were used, the handling depended on multiple factors. Surface EEG, when used in patients with non-contagious diseases, were cleaned with antiseptic soap and inspected before reusing them. The EEG primer makes the following recommendations for non-disposable EEG surface electrodes when used in patients with history of infectious conditions other than Creutzfeldt-Jakob disease, hepatitis, or AIDS. The first step is to clean them with antiseptic soap or ideally with ultrasonic cleaner. Then immerse them in 2% glutaraldehyde or alcohol or 5% sodium hypochlorite for 30 minutes. The same book recommends that for non-disposable EEG surface electrodes in patients with history of Creutzfeldt-Jakob disease, hepatitis, or AIDS, or if we are uncertain about the patient having any of these conditions, to cleanse with antiseptic soap, ideally with ultrasonic cleaner, immerse in 2% glutaraldehyde, alcohol, or 5% sodium hypochlorite for several hours, and then steam autoclave at 132 degrees centigrade for 2 hours. In case of nasopharyngeal electrodes, we should clean them in the same fashion, using cleaning antiseptic soap, ideally with ultrasonic cleaner, then to immerse them in 2% glutaraldehyde, alcohol, or 5% sodium hydrochloride for several hours, and then steam them with autoclave at 132 centigrade for 2 hours. Death electrode in patients with no known infectious or dementia should cleanse with antiseptic soap, ideally with ultrasound cleanser, immerse in 2% glutaraldehyde, alcohol, or 5% sodium hypochlorite for several hours, and then steam in autoclave at 132 centigrade for 3 hours. Death electrodes used in patients with dementia, CDG, or AIDS should be cleansed with antiseptic soap, ideally with ultrasonic cleaner, immersed in 2% glutaraldehyde, alcohol, or 5% sodium chloride for several hours, steam autoclave at 121 degrees centigrade and 15 psi for 15 minutes, immersed in warm detergent solution, and then steam autoclave at 121 degrees centigrade and 15 psi for 15 minutes. Psi means pressure per square inch. But remember, if in the answers you find an option that is disposing of the electrode, then that would be the correct answer for all surface and non-surface EEG recording, regardless of the status of the patient. So the answer to this question is C. The next question is, which of the following montage captures all eye movements as deflection in opposite directions? A. OD, below and lateral, and OS, above and lateral to M2. B. OD and OS, below and lateral to FC. C. Both. D. None. There are two methods commonly used to record eye movements. I will first address the OD and OS to M2 method. This is a representation of the head and the eyes. On the left, the number 1 on the yellow circle indicates the position of the electrode on the left side. That is 0.5 centimeters to the side and up. In older patients, it can be placed 1 centimeter to the side and up instead of 0.5 centimeters. This electrode is then connected to G1 of one of the amplifier used to monitor the eyes. On the right, the number 1 on the yellow circle indicates the position of the electrode on the right side. That is 0.5 centimeters to the side and up. As we mentioned before, in older patients, instead of 0.5 centimeters, the distance can be 1 centimeter. This electrode is then connected to the G1 entrance of the amplifier, monitoring movements of the right eye. Then M2 electrode is placed in the right mastoid. The value of this electrode is taken to be neutral in relation to the eye electrodes. This electrode is then connected to the G2 entrance of both of the amplifiers used to monitor eye movements. Using this montage, all activity arising from the brain will be in phase, as depicted by the different colors wave representing the different amplifiers. On the other hand, eye movements, regardless of their direction, up or down, and to one or the other side, are recorded as out of phase activity, that is, waves going away from each other. So the answer to this question is A. Next question. Which of the following montage captures more eye movements? A. OD, below and lateral, and OS, above and lateral to M2. B. OD and OS, below and lateral to FC. C. Both. D. None. The second method commonly used to record eye movement is the OD and OS to FC method. In this method, the left eye electrode is placed 0.5 centimeters lateral and below the other canthus, as depicted in this figure, and plug into the left side amplifier at G1. The right eye electrode is also placed 0.5 centimeters lateral and below and plug to the G1 of the amplifier on the right. Then an electrode is placed at FC and it is connected through G2 to both amplifiers. With such a montage, electrical brain activity will appear as in-phase waves, that is, the right and the left going in the same direction. Eye movements, when they are in the up and down direction, will also be captured as in-phase activity. But when it is side-to-side activity, it will produce an out-of-phase activity, as you can see depicted in this frame. With this montage, more eye movements will be captured than with the previously described montage. So the answer to this question is B. Next question. Chest and abdominal respiratory movements are best recorded with A. thermistor belt, B. piezoelectric crystal transducer belts, C. both, D. none. The answer to this question is B. The next question is, electrode impedance should be A. 10 to 5000 ohms, B. 100 to 10,000 ohms, C. 100 to 5,000 ohms, D. 10 to 500 ohms. The answer is C. Electrode impedance should be kept between 100 to 5,000 ohms. It is also important that, as recommended by other authors, that the inter-electrode impedance, that is the impedance between all the electrodes connected in one scalp, be within 1,000 ohms of the others. Thank you.